तो ये स्टार्ट कर दें, हो गया काम। और अगर मैंने वो कोई लिखना हो तो लिखना हो तो किसके ऊपर?
मोर चैट
चैट वन, ओके।
बहुत सारा आपको मुझे आवाज
आ रही है, लिखा हो यस। हेलो, कैन यू हेयर मी?
ठीक है सर, जा रही है।
Yes, sir. Okay, great. Yes, sir. Okay. Everyone, yes. How many? कितने कितने लोग हैं? हाँ? How many are there? ये नहीं पता चलता। ओ, थोड़े कम लोग हैं। बाकी कहाँ चले गए? Hello. Yes. Right. Good morning, everybody. I hope you're all well. Enjoying your holidays. Good long break. I hope it is. लेकिन आप लोगों को थोड़ा सा पढ़ना चढ़ना भी है। हम लोग आ जाते हैं आप लोगों को पढ़ाने के लिए कॉलेज में, in this IT room, and try to teach you somehow. कुछ ना कुछ तो आपको समझ आ ही जाएगा। तो I think let's hope that this pandemic is soon nearly over. मेरा ख्याल है कोई महीना, एक अगस्त का महीना जो है उसमें कुछ स्टार्ट होना चाहिए क्लासेस वगैरह। लेट्स होप सो। तो आई थॉट कि आपको वो चीज़ें डिस्कस की जाएं which are very important from the examination point of view, rather than going through just individual topics. But the important thing, the most important presentation usually is that somebody around the age of early 20s comes to emergency with a history of periumbilical pain, shifting to the right iliac fossa, with nausea and vomiting, and temperature and tachycardia. This pain is not settling down. So what comes into your mind first? Because the commonest emergency is appendicitis. So you want to rule out or to prove that this is the appendix, or is it something else? Because it's very important that you take a history. If the patient is not complaining of any urinary symptom, because at the same time it can be UTI or ureteric colic or renal colic, or it could be this appendicitis, acute appendicitis. Similarly, there are other important conditions you should keep in mind. Remember the area of the appendix. It's close to it's at the junction, the appendix itself is at the junction of ileocecal valve. That means ileum, cecum, and if the patient is a female, and it's very close to the tubes and the ovaries. And the ureter is coming down posterior to the cecum, joining the bladder. So all these things should be in your mind when you're taking a history and when you are doing the examination, especially when you're doing an examination. You should always keep in your mind that the Alvarado scoring system. And as you know, Alvarado and the mnemonic of Mantrose, Mantrels. Mental. Mentrels mean migratory pain from periumbilical region to the right iliac fossa. A is anorexia. The patient is anorexic. N is nausea. And T is tenderness. Uh, Mentrel. R is rebound tenderness. T is elevated temperature. L is leukocytosis. S is shift to the left, shift of the curve to the left. So mental is the patient gives up to, if out of these 10, because tenderness and leukocytosis are 2 points each, the rest is 1 point each. So that makes 10 marks. And if somebody is at less than 5, that means you can confidently say that this is less likely to be appendix. Okay, less likely to be appendicitis, less than 5. If it's between 5 and 7, you can say, well, it may well be an appendicitis. Okay, then you do other investigations to confirm that. Okay, but if it's more than 7, that is probably most likely that this is acute appendicitis on clinical basis of Alvarado scoring. Alvarado, okay, don't write down avocado. It's Alvarado scoring system, and the mnemonic is Mantros. Right, okay. Now, then what you need to do is you do an ultrasound scan, which is very important, and ultrasound scan will tell you if there's any ureteric stone. The ultrasound scan will tell you that there is a hydroureter. That means the stone is blocking the ureter, and proximally the ureter is distended or dilated. We call it hydroureter. And if that extends to the kidney, then you can say it's hydronephrosis. Okay, so that's one thing. The other thing is you can actually some specialized probes. Probes is when you're doing an ultrasound scan, that instrument is used with the jelly on. जली लगा के तो उसके ऊपर हाथ में अल्ट्रासोनोलॉजिस्ट के हाथ में प्रोब होती है जिससे वो पिक्चर देखता है. There are specialized probes to see the diameter of the appendix. Okay, and sometimes they can see even if it's a small ficklet causing obstruction, which is the obstruction of the lumen of the appendix. Okay, which is obstructive appendicitis that needs an operation. The other type of appendix is non-obstructive, or you can say it's a catarrhal appendicitis, catarrhal inflammation. It's just an inflammation, not causing obstruction, not obstructive appendicitis. If there's an obstruction, it's likely that it might perforate, so you have to do it. Okay, right. So that's the let me do ultrasound scan, and on top of that, in certain developed countries, they go straight to CT scan, and CT scan will tell you exactly the length, the diameter, the wall thickness, and presence of ficklet or not, and they can help you in diagnosing different diagnostic modalities, ultrasound scan, and this thing. If it's a female, don't forget to do urine testing, urine examination, pregnancy test, beta HCG. Make sure the patient is not pregnant earlier on, and sometimes it can be an ectopic pregnancy presenting like symptom like appendicitis. It mimics with appendicitis the right-sided ectopic pregnancy. Uh, you'll say the patient is very tender in the right iliac fossa, it's acute appendicitis, and when you do the pregnancy test comes back positive. Mm, So instead, it is ectopic pregnancy. But the ultrasound scan will tell you that there is some collection of the products of conception in the area. So you know that it's ectopic pregnancy rather than appendicitis. Differential diagnosis of appendicitis is very important. Know about the ureteric colic, UTI, acute salpingitis, salpingo-oophorytis. It could be ovarian cyst, torsion of the ovarian cyst. It could be enteritis, just the inflammation of the terminal lining, like Crohn's disease, like tuberculosis. Okay, and I think if there is some kind of a mass in that area, it could be appendicular abscess, appendicular mass, or if it is a child, it could be intussusception. That means invagination of the proximal bowel into the distal loop. So that gives a mass, it gives a very severe pain, and sausage-shaped mass in the periumbilical or right iliac fossa in a child. Sometimes they also have some blood per rectally, leading PR. Because of the invagination, it causes uh, injury to the uh, intussusceptum. As you know, the intussusception, it's the process. Okay, ये एक एंटिटी है, डिजीज एंटिटी है, कंडीशन है, इसका नाम है इंटरसेप्शन, जो प्रॉक्सिमल बाउल इन्वेजिनेट करके दूसरे लूप के अंदर जा रही है, अंदर घुस रही है, और वो जो बाउल है जो रिसीव कर रही है उसे कहते हैं इंटरसिपिएंट्स, और जो लूप अंदर जा रही है उसे कहते हैं इंटरसिसेप्टम. तो इंटरसिसेप्टम जो है इंटरसिपिएंट्स के अंदर घुस रहा है, and it causes reduced blood supply and ischemia and process sometime bleeding and obstruction and a severe pain in the child. Usually the triggering factors are sometimes little polyp or इस तरह की कोई ऐसी चीज हो सकती है, or when you change the diet of a child, sometimes it causes invagination, and sometimes Meckel's diverticulum itself. Last time I mentioned about Meckel's diverticulum, the rule of two. It can be present in 2% of the patients, and it can cause invagination, can start from there, and it can cause interception. So the treatment of interception, as you know, is when you've done the examination, you feel a mass, severe pain, child is crying, vomiting. You can feel a mass in the periumbilical right iliac fossa region, sausage-shaped mass, and you do an ultrasound scan, you see a mass there in that area, and you need definitely NG tube, IV fluids. You resuscitate the child, and you plan for surgery to try to reduce the uh, intercepting area, उसको पुल करके जेंटली उसको स्क्वीज करके जो अंदर इन्वेजिनेट हो गया हुआ है द पोर्शन द बाउल, उसको बाहर निकालें. Sometimes it's gangrenous or damaged, or it doesn't come out because it's all too late. A surgery, in that case, you have to resect and do end-to-end anastomosis. So that's the process is intussusception. So it's one of the differential diagnoses appendix as well, appendicitis as well. Okay, And similarly, is another rare condition is fortunately not very common. It's called carcinoid syndrome, carcinoid tumor. It arises from the most common organ of carcinoid tumor is appendix, and it can be the rest of the alimentary tract, including the ileum or the large bowel, but it can be lungs, and this carcinoid tumor can metastasize to the liver, and it secretes 5-hydroxytryptamine, that is serotonin, and if it's metastasized to the liver, then the 5-hydroxytryptamine that is released directly into the hepatic vein and into the systemic circulation. So you can develop a carcinoid syndrome, which is, you get a cyanosed red face after eating a food or alcohol because of this 5-hydroxytryptamine in the circulation. So this the commonest site of carcinoids in tumor is appendix. If you look at macroscopically, it looks sort of a yellowy, cheesy kind of a tumor in the appendix. Luckily, most of them, because it causes some fibrosis uh, throughout in the serosa and inside submucosa, and sometimes ulceration in the mucosa as well. And it causes obstructive kind of appendicitis, and it metastasizes to the regional lymph node. That's why it's called a carcinoid tumor. It can be very dangerous, and sometimes when you open for appendicitis, you see this brownish, yellowy, cheesy tumor in the appendix, and you have to resect it with a free resection margins and make sure there are no liver metastases. So that's one of the things. And how do you confirm that? You can confirm that because this these are from Kulczewski's cells. Okay, neuroectodermal in origin. This tumor is carcinoid tumor of the appendix. It's neuroectodermal, derived from the neural crest. Okay, like other gastrinomas, insulinomas, and other neuro, gastrointestinal, or pancreatic tumors, which are of neural crest origin. This is one of those kind of things. And it secretes 5-hydroxytryptamine. So if you collect the urine, 24 hours urine sample, so that 5-hydroxyindole acetic acid, which is the product secreted in the urine from this 5-hydroxytryptamine. 5-HIAA, 5-hydroxyindole acetic acid, is collected in 24-hour urine sample. You will see that this is highly elevated. Or another thing is you can check the serum chromogranin levels. That can give you well some indications. And the other thing is an ultrasound scan, CT scan to see if there's a tumor or something there. And the treatment is you resect the carcinoid tumor, and also sometimes octoroid analogs are helpful. Octoroid analogs are they compete with somatostatin receptors in the appendix and can help in the treatment of uh, uh, these tumors. Okay? So that's another thing that you should remember is It could be carcinoid tumor of the appendix, just rather than acute appendicitis. So these are the rare things, but you should always, sometimes you might see, write a short note on carcinoid tumor. You should know that uh, the most common site is appendix. It can be uh, the intestine as well, but what it is, it's a neuroectodermal in origin. Okay, so and it secretes 5-hydroxytryptamine, which is a serotonin. Action like serotonin, this you can cause bronchospasm, cyanosis, and red plethoric phase after having the food and especially after alcohol to confirm that. Okay. Right, that's one thing. Right, and the other possibilities are, uh, as I mentioned, the ileal diseases, Crohn's disease, it could be tuberculosis, uh, urinary system diseases, it could be, uh, if it's an elderly person, well, elderly means middle age, like 40 or 50. That's very important to remember. Sometimes the presentation is such that a patient, 40-year-old, 45-year-old patient brought to you emergency with pain in right iliac fossa. And when you examine, you feel a mass there. Okay, patient is anemic, has a bit of diarrhea, and there is some mass in the right iliac fossa. So you suddenly the mind should start clicking that it could be a carcinoma of the cecum. So one of the differential diagnoses of acute appendicitis and appendicular mass is that it could be uh, carcinoma of the cecum, and that would require a right hemicolectomy rather than just the appendicectomy. Okay, so uh, I think I mentioned before, but I'll just repeat it for completion's sake that sometimes people ask you is a mass following appendicitis in the right iliac fossa, how would you manage that? Discuss the management of the appendicular mass. So most of the time, the management of appendicular mass is initially conservative and watching the mass, keeping the patient in the hospital, in the ward, and examining daily to see the size of the mass, to see uh, the response of the IV antibiotics treatment. If the temperature is coming down, white cell is coming down, patient is less symptomatic and symptoms are improving gradually, the size of the mass is shrinking, that means the antibiotics are working. So you continue with the antibiotics, and in that case, you deal with the appendix when patient is completely settled. You send the patient home uh, with antibiotics, oral antibiotics at home, and bring them back after 6 to 8 weeks to do an elective appendicectomy. And the other term used is called interval appendicectomy. That you give an interval, you treat the patient conservatively in the hospital with IV antibiotics and conservative management of IV fluids. Once the patient is settled, send the patient home, bring the patient back after 8 weeks, and do an elective appendicectomy so it should not happen again. Okay, so that's the management of the appendicular mass. But that is if the patient start responding to the antibiotic. But what if the patient doesn't respond in the ward? the mass is increasing, the temperature goes up, white cell goes up, ESR up, the CRP is going up. That means it's getting worse. That means the appendicular abscess or the mass is increasing in size, is not getting better. In that case, you have to go in and sort out the abscess or the appendix or whatever, because you can't leave it like this. Patient is responding, fair enough. You can sit back, sit tight, and let the antibiotics work. Let the patient deal with preservatively. But if it's getting worse, then you've got to open it. You've got to go in and do a surgery. Okay, so you should all know where the appendix normally is. Okay, so look at this picture, and you can see that this is an ileum, this is ileocecal junction. The commonest position is retrocecal. It's behind the cecal. Okay, the commonest position is retrocecal. Then comes the pelvic, that is towards the pelvis. The other positions to look for the appendix it can be paracecal, that means parallel to the cecal. It could be a pre-ileal, post-ileal, that means behind the ileum or in front of the ileum, and subcecal, that means below the cecal. Okay, these are the various positions. You should know where the appendix could be when you open up, and वो आपको आपका ऐसे जो कहते हैं सर वो खोल लिया मैंने वो अपेंडिक्स मिल नहीं रही तो नज़र आ रही कहाँ पता नहीं कहाँ घुसी हुई है. So if you have an idea, the commonest is below the behind the cecum, retrocecum. Then you should know where to look for. But the best thing is, it starts, the base of the appendix originates when the three tinea coli of the cecum, they join in, where they join in, the appendix starts. And it is close to the ileocecal junction. So the 2 points remember, ileocecal junction, look for the ileocecal junction, look for the tinea where they're ending, and the base of the appendix starts there. So once you've got the base, then you can trace the whole length of the appendix. Okay, so that's one thing. Okay, how to locate the appendix. Now, it's not necessarily that the appendix is always in the right iliac fossa. It could be on the left side, because of the malrotation. The intestine is malrotating and the appendix is on the other side. So, ऐसा भी हो चुका है कि a lot of people, the registrar level, सब वो खोला है वो मुझे तो कहीं अपेंडिक्स नज़र ही नहीं आ रही, तो वो स्मॉल बाल को पकड़ के देखते रहते हैं कि शायद इसके साथ लगी होगी. ऐसा नहीं है. You have to follow the small bowel to the terminal ileum and the ileocecal junction. If you have this thing in your mind, go for ileocecal junction and look for the tinea. You remember these tinea coli. These are the longitudinal muscles of the large bowel, right up to the sigmoid. They don't go down into the rectum. Rectum does not have tinea coli. Okay, remember that. Rectum does not have tinea coli. It just finishes at the end of the sigmoid. This is a sigmoid coli. Okay, it starts at the cecum, right up to the sigmoid. Now follow the tinea coli, follow the junction, and you can reach where the appendix is. All right. That's one thing always remember. And once you look at this, you see this is the cecum, okay? This is the cecum region. You can see the appendix, that's the tip. That's the base, and these are called Babcocks. Babcocks. Okay, they're called Babcocks. Now, the most important thing. This is appendicular mesentery. The appendicular mesentery, and you can see the artery of the appendicular artery is coming there and giving branches to the appendix. Okay, you have to ligate this. Now, for appendicectomy, you have to give a gridiron incision or a Lanz incision, which is in the skin crease. If you want to give a nice scar, use Lanz incision, Lanz, Lanz incision or gridiron incision, which is at right angle to the line joining the uh, umbilicus and the anterior sphenocardiac spine from medial to lateral one-third junction, which is McBurney's point. Okay, so you should know all these where McBurney point is. Now, if you look at macroscopically at the section of the appendix, okay, they start from the mucosa, submucosa, and you got muscularis, and you got the serosa. Okay, so it's just like the rest of the uh, intestine is the same as the intestine. As you know, it's the rudimentary part of the intestine, vestigial organ. They say we don't know that a lot of lymphatic functions are there because there's a lot of lymphatic drainage. All right. Now, now if you look at this, this is you pass the colonoscope through the rectum and all the way through the transverse colon, descending colon. This is the picture inside. You can see the opening of the appendix through the scope. Your scope is there. You are looking at the opening of the appendix in the cecum. The appendix is way down there. So, and you can see some debris there, feculates there, that can cause a distal obstruction. Do the abdominal X-ray, sometimes you can see the feculates in that right iliac fossa region, okay, on the X-rays. And if you look at the inflammation, heavy infiltrates, inflammatory infiltrates, extending the whole full thickness of the appendix. Look at that, it's the mucocele. It's the mucus, all mucus causing distension of the appendix. This is a specimen when you remove the appendix and you send it, and there's a lot of mucocele, mucus there, okay? And if it's full of pus, it's called empyema of the appendix, just like the gallbladder, mucocele of the gallbladder, or empyema of the gallbladder. Similarly, is the appendix. Okay. Now, what are the risk factors for perforation of the appendix? Okay. If it perforates, pus is comes into pelvic cavity or peritoneal, the prognosis of peritonitis is pretty bad as compared to just doing an appendicectomy. So you should always make sure that you don't delay it uh, and don't let the perforation. But what are the risk factors? Which person is more likely to perforate the appendix? Extremes of age groups. Elderly people, if it's an elderly person having appendicitis, is more likely to perforate. Okay, because of the low immunity, He's got so many other conditions, so he's likely to perforate with a bad prognosis. Similarly, if the child is more likely to perforate as compared to the adult, and because in adults we have a momentum, greater momentum. Any inflammation, greater momentum goes there around the appendix and holds the appendix, keep the infection in that area. This is why the greater momentum is called the abdominal policeman. And inflammation, the greater momentum goes in that area. And in a child, there is a the size of the greater momentum is very small. So you cannot go to the right iliac fossa and less likely to seal that inflamed area. So it's more likely to perforate. So extreme of ages are the risk factor, right? Similarly, if somebody is immunosuppressed, is likely to complicate the appendicitis. Right? Diabetic patients, it's a fecalith obstruction. If there is an obstruction, and if the obstruction keeps on going, the distal tip of the appendix will perforate. Similarly, it's a pelvic appendix, a lot of adhesions in the area, just like the any previous abdominal surgery, and you get caught in those adhesions and more likely to perforate. Okay. Now, coming back to the what are the symptoms? As you all know, parambilical pain, and it shifts to the right iliac fossa. First is around the belly button, shift to right iliac fossa. Patient doesn't want to eat anything, doesn't like to eat anything, is anorexic, and is feeling nauseous and sometimes vomiting a few times. So this always comes into your mind. This is one of the commonest surgical emergencies. Okay, then what are the clinical signs in situs? Well, the clinical signs are the ones which a doctor, uh, you know, can detect or can see or elicit. For example, the patient is got temperature, you check with the thermometer and say that yes, the patient is got pyrexia, or you touch the forehead of the patient with the back of your hand and they'll feel hot. Uh, you examine the right iliac fossa and you say there's localized tenderness. And when you try to press it down, you will feel that the muscles are guarded, but stiff in the right iliac fossa because patient is trying to guard the inflamed area with the tightening of the muscles. So when you examine it, the muscles are guarded. And if you press it hard during tenderness and suddenly lift your hand up, it's called rebound tenderness. The patient gets sudden uh, quick pain. This is called rebound tenderness. You press it hard and suddenly lift your hand up for rebound tenderness. Okay, these are the clinical signs in appendicitis. And as I mentioned, there are two clinical pictures in acute appendicitis. One is a catarrhal, that is just the non-obstructive one inflammation, catarrhal inflammation without any obstruction. The other is obstructive, as I mentioned earlier on. Okay, the obstructive one is the one which warrants early operation. Right now, what are the signs? Sometimes the examiner asks you, or in the theory paper, what are the signs to elicit in appendicitis? I remember many years ago when I was appearing in lab examination, this question, और हमारे यहाँ क्या होता है ये सवाल देते ना discuss the signs of appendicitis. तो ये जनाब पूरी उस पर पूरी कॉपी जो है ना वो शीटों पे शीटें शीट शीट हाँ उस पर लिख दूँ भाई ये सिर्फ ये पूछा गया है व्हाट आर द साइंस इलिसिट appendicitis ये साइंस कौन से हो तो 4 लाइनें उसमें लिखनी होती हैं बजाय इसकी शीटें भरने के just write down these few things okay which you will detect to confirm that this is appendicitis okay the doctor you notice that the patient is excuse me patient will be pointing with a finger where the pain is. You ask the patient, where is hurting your tummy? It's bothering you in your tummy or where is painful? वो अपने हाथ से या उंगली से आपको पॉइंट करके बताएगा कि that's where it's hurting. It's called pointing sign, rousing sign, rousing sign. If you patient is lying supine on bed and you press the left side of the iliac fossa, left abdomen, and the patient will feel the pain on the right side of the appendix. तो लोग कहते हैं दबा तो आप लेफ्ट साइड पे रहे हैं पेन उसको राइट साइड पे कैसे होगा तो व्हेन यू प्रेस इट तो बावल जो है लेफ्ट साइड की वो आप प्रेस करते हैं तो मूव करके ना दूसरी तरफ जा रही होती है राइट साइड पे when it goes there, it touches that inflamed appendix and that causes pain. It's called rousing sign. Okay? Bowel to move the press it on the left side, pain on the right side. Now, saw sign. As you know, the commonest position of the appendix is retrocede. Okay? Retrocede. तो उसके सीकम के पीछे अपेंडिक्स है और उसके पीछे सॉस मसल आ रहा है सॉस मेजर तो अगर इन्फ्लेम्ड अपेंडिक्स होगी तो सॉस मसल जो फ्लेक्सर है थाई का वो ऐसे वो कर तो आप जाके पेशेंट को देखेंगे ना तो उसने अपनी टांग जो है ना ऐसे फ्लेक्स करके रखी होगी बिकॉज ऑफ द इन्फ्लेमेशन ऑफ द अपेंडिक्स द रेट्रोसीड कंडीशन ऑब्चुरेटर साइन सिमिलरली अब ऑब्चुरेटर इंटरनस मसल कहाँ पे अंदर ही है ना साथ उसके नीचे पेल्विस में तो अगर पेल्विक अपेंडिक्स है तो दिस विल गिव राइट होता क्या है कि एक तो हिप फ्लेक्स होगी एंड इट विल बी इंटरनली रोटेटेड okay? Flexed hip and internally rotated patient will have pain so these are the 4 signs that you should remember pointing sign, rousing sign, soft sign, and obturating sign. And of course, the rebound tenderness. All right? Which is the cardinal sign. Now, usually the question comes what is the differential diagnosis in children? What is the differential diagnosis in adults? What's the differential diagnosis in females or an elderly person? The differential diagnosis in children. A lot of patient gets gastroenteritis, infection of the intestine and stomach. You start vomiting with temperature and abdominal pain, so you should know that, keep that in mind. Because आज से इस टाइम मैकडॉनल्ड से या कोई टेक अवे तो नहीं लिया या कोई इस तरह की चीज़ तो इधर से नहीं खा रही बाजार से नान लीन तो नहीं खा ली Similarly, mesenteric adenitis, throat infection, patient child is having cough and this and that. Similarly, with the bugs होते हैं, they in the mesentery there are lymph nodes. They get inflamed and enlarged and cause like fossa in the mesenteric region, terminal island. Get lymph nodes there. Okay. And similarly, in a child, you can suspect a macro diabetes, and that can give rise to similar pain interception, as I already mentioned. Enoxomnum purpura is purpura of different different types. This is the one that purpura, bleeding in the region, in the area, can give rise to very rare. Similarly, lobar pneumonia, the lower lobar pneumonia can give rise to pain, radiated pain into the right lower abdomen. So that's a differential diagnosis. Child. What about the adult? It could be a regional enteritis, inflammation of ileum. It could be colic, sometimes perforated peptic ulcer. You know why it's given as differential diagnosis of acute appendicitis? Peptic ulcer तो पेन इसकी upper gastric region में होती है. It says perforated peptic. तो जब वो लीक करता है ना, परफरेट करता है, तो वो जो सारा कुछ निकल के कलेक्ट इन द राइट एलिक फॉसा. पेशेंट को पेन राइट एलिक फॉसा में होती है. So that's also differential. Torsion of the testes. As you know, the testes is an abdominal organ. You descend होकर नीचे जाता है, so the nerve supply is up there. Whenever there is a torsion of the testes, the pain is up in the abdomen, in the right abdomen. Pancreatitis causes generalized fluid in the abdomen, and it can cause pain in the right side of the lower abdomen. Rectus sheath hematoma. गेम खेलते हुए फुटबॉल लग गया, क्रिकेट बॉल लग गया इन द राइट साइड ऑफ द एब्डोमेन. शीथ जो है रेक्टस शीथ के नीचे ब्लीडिंग हुई है, वो हेमाटोमा से बन गया है. You touch the abdomen and the patient is very tender, you think it's an appendicitis. So active life pain, adult life pain, it can mimic as appendicitis. Right, next comes adult female. 24-year-old lady, if your age, and she has the pain, the right side, always make sure it's not mitral spurs. Mitral spurs, as you know, you've done your gynae a few times, it is the mid-cycle pain. You ask the patient when did the period start, and you calculate 14 days from that day onward, and uh, at the time of ovulation, there is some pain on the right side, okay? Right, well, it is the right ovary ovulating that can give rise to pain mid-cycle, middle spurts. Pelvic inflammatory disease, the inflammation of the tubes or ovaries. Pyelonephritis, inflammation of the valves of the kidney and the ureter. Ectopic pregnancy, we already discussed. Torsion, twisted ovarian cyst, or the ovarian cyst get ruptured, can cause right outburst pain. Endometriosis can give rise to pain. The right iliac fossa or the left iliac fossa, it varies. Yes. Then comes the elderly person. You've got an elderly person, it could be diverticulitis, it could be intestinal obstruction, it could be carcinoma, mesenteric infarction, leaky aortic aneurysm, it could be torsion of the appendices, epiploidy. These are the little fat globules around the colon, appendices epiploidy, and it's a twisted uh, this appendices epiploidy. It can give rise to abdominal pain. And this is the right iliac fossa, so it can mimic the appendicitis. It's less likely in elderly and usually misdiagnosed because you don't expect elderly people to have an appendicitis. I remember operating on 90-year-old and it was an appendicitis, mind you, okay? Always remember, never just disregard that elderly people can't have an appendicitis. हो सकता है. You always keep your mind open and make sure that you're not missing out on anything because the elderly people don't do well if you misdiagnose. Okay, uh, and this comes, as I mentioned, Alvarado scoring system. Ventrals, as you can see, the tenderness and leukocytosis are two scores, the rest of one, so its total is 10. Okay, Alvarado and Ventral. Memorize this, okay? You have to memorize this. Now, we're coming towards the further investigations. Like you do an ultrasound and a CT scan. You can see both of them, and this showing the features of appendicitis. And here you see the CT scan, the reticulate and the appendix. Okay, all the way down. This is the appendix, inflamed appendix, and the reticulate causing obstruction. You've got to do surgery, remove this appendix. Okay. Now, what investigations are important in basically in any kind of abdominal pain, full blood count, especially in you want to exclude any urinary symptoms, urinary problems. So you do urine analysis, urine examination, and there are certain selective. For example, you suspecting a lady ectopic pregnancy, do pregnancy test. Routinely, you do urea and electrolytes, abdominal X-rays, ultrasound scan, abdominal pelvis, contrast enhanced CT, abdomen and pelvis. Okay, computerized. It's contrast enhanced CT. Now, I'll just stress one point here. You should always remember when you come to a house job, you should know this. What is contrast enhanced CT? One is a plain CT, okay? But you want to see the internal organs and the complete pictures. So what you do is कि आप डाई इंजेक्ट करते हैं डाई कहना नहीं चाहिए कंट्रास्ट कहते हैं ठीक है कंट्रास्ट आईवी देते हैं that goes into circulation and ये इंटेंसिफाई करता है जितने ऑर्गन हैं जिसको आप देखना चाहते हैं ठीक उसको करने के बाद it gets excreted through the kidneys in this contrast. Now, जब भी आप सीटी स्कैन कंट्रास्ट एनहेंस स्कैनिंग कर जाएंगे तो रेडियोलॉजिस्ट एक चीज़ आपसे पूछेगा आपने इसके RFTs करवाए हैं रीनल फंक्शन टेस्ट करवाए हैं दैट मीन्स यूरिया एंड क्रिएटिनिन करवाया आपने अगर आपने नहीं करवाया तो वो कंट्रास्ट सीटी नहीं करेगा बिकॉज this contrast is going to be excreted through the kidney. तो अगर किडनी फंक्शंस पहले से खराब हैं आपने ऊपर से कंट्रास्ट दे दिया कंट्रास्ट इज गोइंग टू स्टे इन द बॉडी इट्स नॉट गोइंग टू बी एक्सक्रीटेड और ड्यूरिंग एक्सक्रीशन इट फर्दर डैमेजेस द किडनी तो आप रीनल फेलियर करा देंगे इससे बेहतर यह है कि प्लेन सीटी करा लें किडनी फंक्शन नॉट compromised. The kidney functions compromised, azotemia है, renal failure के chances है, then just plain CT would do. Okay. Now, the other important thing, I thought मैंने वो आपसे कहा था कि line joining from the umbilicus to right iliac, anterior spherical spine, and a line right angle medial 2/3 to lateral 1/3. There's a point called McBurney point. This is gridiron, okay? Gridiron section. Now this is the Lanz incision. Spring tree, the metacarp. All right. Okay, so that's the Lanz incision. This is the gridiron section. How are we doing from the? Oh, we got a couple of 3-4 minutes more. All right, quickly go on to the, oh, what is it? What's happening? Gosh. Do that. Right. Now this is uh, how you do the appendix through the McBurney spine. You give a great incision. You go through the external oblique epidurosis. You cut the external. Not try to remember it. Go with cut and split. You cut the external oblique. You split the internal oblique. You split the transverse abdominis muscle. Go to the peritoneum. You cut the peritoneum, and then you get Escherichia coli and the ileocecal region and ligate the base of the appendix. That's a cecum. Ligate this and divide with a knife underneath the artery forceps and remove the appendix and put a little purse string sutures and tie it and then divide this thread. So sometime I remember they asked what are the different steps in appendicectomy. So it's a gridiron incision, skin subcutaneous tissue, external oblique aponeurosis is is cut in the line of incision. External oblique is divided, process divided. Number one muscle, external oblique, then internal oblique and transverse abdominis muscles are split. Peritoneum is opened and the appendix is removed. Okay, time. Oh, sorry. I've been reminded that the time is over, so at least we've covered as much as I could tell you. Okay, we'll see you next time then. Always remember it's open and laparoscopic appendicectomy. Well, all right. Okay, good night. Goodbye.
Stop, sir.
Huh?
Stop, sir.
Stop.